Welcome to lecture for Abnormal Psychology. We'll be talking today about neurodevelopmental and neurocognitive disorders. For the neurodevelopmental disorders, we'll talk about intellectual developmental disorder, also referred to as intellectual disability, communication disorders, autism spectrum disorder, ADHD, specific learning disorder, and motor disorders. And then for the neurocognitive disorders, we'll talk about delirium and major and mild neurocognitive disorders, formerly known as, referred to as dementia. Okay, so the neurodevelopmental disorders. Well, one thing to keep in mind is, even though these disorders have developmental in the title, all disorders are really developmental, right? They all have a developmental trajectory. They have developmental influences. Most disorders that are in the DSM, there's some phenomenon, biological, psychological, both, that influence the expression of those disorders that are occurring in infancy, childhood, the developmental period. So all disorders are developmental, but the neurodevelopmental disorders, part of the reason that they have development in the title is the onset is typically in the early developmental period, where you actually meet criteria in childhood or adolescence. And also, it seems to be there's a developmental deficit or delay that causes impairment. Right? If we look at typical development, which it's important to have a solid foundation understanding of typical developmental patterns to be able to understand the neurodevelopmental disorders, understand abnormal psychology. Because what seems to go on is typically there's a sequence of things that happen. You know, you master this, and then you master this, and then this area, and the area of focus of energy, attention in development shifts across time. Once things are successfully, okay, you figured this out, now you do this, right? You don't master abstract thinking before you master concrete thinking. Concrete comes first. It's one of those truisms of development. What seems to happen for some neurodevelopmental disorders is there's either a delay in development or a deficit where somebody doesn't master something, and then that then has a bit of a domino effect. Well, okay, because this wasn't mastered, it's going to cause problems in other areas on down the road that eventually will lead to identifiable impairment. So, what are the disorders? Intellectual disability, also referred to as intellectual developmental disorder. Formerly referred to as mental retardation fairly recently, but then Rosa's law was passed, which changed the wording in several settings in the way that the federal and state governments and educational institutions refer to people with intellectual disabilities, taking the words mental retardation out and substituting intellectual disability, because over time mental retardation had developed a bit of a pejorative connotation, had been used as an insult, and so the community felt it was important to change the language. Well, okay, if this word is going to be used to insult people, okay, keep your insult, call people this other word, but you know, for the people that actually have these cognitive impairments, we're going to use different words now. You take that word, we're going the other way. So, in terms of DSM criteria, to be diagnosed with intellectual disability, have to show a deficit in intellectual functioning that's confirmed by clinical assessment and standardized testing. So intelligence tests like the WAIS for adults, the WISC for kids, or Woodcock-Johnson for either one. And typically on those tests, you know, they're standardized, normed tests, so everybody gets the same questions in the same order, and a large group of people have taken them in the past, so we know what the average or typical score, the typical number of questions correct on any part of the test is. So based on that, you can look at how many questions somebody else gets right and say, okay, yep, they scored the same as the average, or they scored more than average, or less than average, and it's standardized in terms of, statistically speaking, you get a standardized score. That is a score that tells you how many standard deviations you are above or below the mean. And for to meet this criteria, typically what's set is if you're 2 standard deviations below the mean. Most IQ tests are normed, they're standardized where the mean is 100. So 100 IQ is average. So to meet criteria for this intellectual disability would be if you have a standard deviation of 15, 2 standard deviations below is 70. Some organizations say 75, give you a little more wiggle room in there. Because again, those tests aren't precise. You know, when you get a score, usually there's a window around the score. So, okay, your measured IQ is 72, but it's 72 plus or minus 4 points, 5 points, depending on what test we're talking about, the standard error of measure involved, because there is measurement error in all assessments. You have, your true score is probably in a range around your measured score, depending on the variability associated with that test. So, but generally about 2 standard deviations below the mean, which is, if something's normally distributed, you look at the normal curve. If you're 2 standard deviations below the mean, you're looking at, about 2.5% of the population being that low. Same thing for 2 standard deviations above the mean. IQ is above 130, about 2.5% up there. And this 2.5%, that unsurprisingly, is about what the prevalence rate is in general population. It's about 2%. Okay, so this kind of identified deficit in intellectual functioning isn't enough to be diagnosed with intellectual disability. So you have that, but if you don't have the rest, it's not intellectual disability. You also need to have deficits in adaptive functioning that result in failure to meet developmental and sociocultural standards for personal independence, responsibility, that limit functioning in one or more activities of daily life. Oof. So what does that mean? Okay, well, first of all, these deficits in adaptive functioning, in figuring stuff out and getting stuff done, are related to the deficits in intellectual functioning. They're not separate things. There's some sort of logical connection between the two. Because of your difficulty thinking, problem solving, you're having difficulty accomplishing things in the world. So adaptive functioning, adapting to challenges you face. Oh, the toaster's broken. What do I do? Okay, I check if it's plugged in. I do this, right? Real world solving problems. So a failure to meet developmental and social cultural standards for interpersonal dependence. So developmental standards, right? The expectations for what you should be able to do yourself change across time, right? You don't let your 2-year-old pour the milk, right? It's not something that you have a developmental standard that no, they shouldn't do that themselves. But when they're 12, yeah, you can pour your own milk. If you can't, okay, then you're starting to fail to meet this standard. And there's also a socio-cultural standard, because one of the things we look at in terms of this is about personal independence and responsibility, being able to do things for yourself. If you're in a culture where you're expected to not move out, you're expected to stay at home, and the norm, cultural norm, is for your parents or someone else to do your laundry and take care of lots of things. Okay, well, if you're not doing them and they're doing them, but it's culturally appropriate, you don't meet criteria. Now, if you're in a cultural setting where you're expected to do those things but can't, and you can't because of this kind of intellectual deficit, then you do meet criteria for that. Right? So, and then it limits functioning in one or more activities of daily life. So taking care of yourself, going to work, going to school, kind of major life areas. So the intellectual deficit, and then also it's because of the intellectual deficit, you're not able to take care of yourself or get some things done that are expected of you for your developmental level and your cultural context. And again, not able to get those things done without some support, because obviously people with intellectual disabilities can often thrive, but they just, to meet criteria, they need some extra support to be able to do those things. And then the onset of the deficits is during the developmental period. I thought this was a little interesting. DSM-5, one of the changes is it used to just say onset before age of 18, and they took that out. They said, well, that number's arbitrary, so let's just put a vague phrase in instead. But still, the general understanding is they mean before the age of 18. But they changed the wording to allow for, well, some people may develop slower, so if there's onset at 19, maybe it still is. But typically it's not. Typically, it's from birth, early childhood, and you want to, because you want to distinguish this intellectual disability as a developmental disorder from people that have kind of a typical pattern of cognitive development, intellectual functioning, and then they have some sort of brain injury or trauma or disease that causes impairment. That's a different thing. That's not the same thing as intellectual disability, right? So again, onset is early on, and typically those deficits are seen in childhood. Okay, you specify the severity of the intellectual disability. It used to be the severity was based on IQ score, right? So to meet criteria at all had to be IQ at or below 70, and they drop down. Okay, well if you're below 55, it goes to this, it goes to this. From mild, moderate, severe, profound. That's changed in DSM-5. Now severity is based on abilities in 3 different domains. The conceptual domain, which is that thinking, cognitive reasoning, social domains, being able to interact with others, and then practical domains, which is a bit of that adaptive stuff, being able to take care of yourself, hygiene, those types of things. With the majority of individuals with intellectual disability are in the mild category. So they have their IQs are not too far below 70. They have some difficulties with reasoning, and some impairment with interacting, and some difficulty taking care of themselves independently without some help. But it's not that profound. Oh, this, all these people have to be at a level of help. They have to be in an institution. Again, most people are able to function in independent settings with just some support, especially if they have family involved. In terms of identifiable causes of intellectual disability, maltreatment, deprivation in childhood. If you just don't interact with kids and you starve them and you abuse them, that can cause intellectual disability, right? Because there's this kind of developmental window where you need exposure to certain things for the brain to develop appropriately, and that on the severe end of mistreatment, they can miss the window. That's really hard to make up. That's becoming more rare in the developed world, thankfully. Chromosomal disorders like Down syndrome, infectious diseases, which again becoming less common, and then exposure to toxins, which the biggest one there being alcohol, fetal alcohol syndrome. If a pregnant woman drinks a large amount of alcohol during pregnancy, and particularly during the early stages of pregnancy, it causes diffuse brain damage, right? So, and that's why you see these for fetal alcohol syndrome, these varied patterns of deficits. Well, this kid has this problem, this kid has this problem. They aren't the same problems. It's the same thing. Yeah, because the toxin that they were exposed to in utero affected different parts of the brain for those kids. So there's some cases where, oh yeah, this is why this is there, but the majority of cases, the causes don't have a clearly identifiable cause. Right? It seems to be, probably some degree hereditary, maybe some lack of exposure to education, or just we don't know. That's interesting. Their brain developed differently. The intervention depends on severity and need, right? So again, with most people having mild intellectual disability, you just need some support, some training, teaching life skills. Sometimes I have a friend who's lives in a kind of assisted living type setting, from the age of 22, I guess. So there's an apartment complex that basically has young individuals with intellectual disabilities, and they have some case managers on site that will check in on them, but they take public transportation to go to work and come home and they have relationships and they live pretty independently, but they live in a place where somebody will kind of check on them and make sure, if something happens, there's somebody there that can help them problem solve. To where on the severe end, you have individuals that are not capable of living independently and will likely be institutionalized for life because they would be a danger to themselves otherwise. I would also say the word here is intervention, not treatment, because again, this isn't typically seen as like a disease that needs to be fixed. This is okay. These individuals have a different level of cognitive functioning. It's not something you're going to fix or change. It's not really broken. They're just different, but they may need some intervention to help them be successful and maximize the degree to which they can live autonomously. And along those lines, there's been a push in the past more than 20 years now for an inclusion movement in public schools, right? Where for a while you had kids with intellectual disabilities, you'd separate them and they'd go at a separate part of the school and all be together, where you'd had kids with very different levels of disability, kids with mild, moderate, severe intellectual disability, all just in one classroom together. And also kids lumped in there too with emotional disturbance and other things, and they're kept separate from everybody else. And there's been a push to say, let's not do that all the time, because they will need some separate instruction, right? Where people will be working with them, teaching them things that neurotypical kids without intellectual disabilities don't need that instruction. So they will need to go separate some, but the majority of the day, they could probably be included in a regular, a mainstream classroom. And that seems to be a helpful variety of reasons, especially in terms of socialization, decreasing stigmatization. And they're not so odd and different that you never see these kids. Oh, that kid's in my class. I know him. I know her. And it becomes a little more normalized for other people and for themselves. There's a couple of communication disorders in the DSM, typically deficits in language, speech, and communication. Language disorder is where you have difficulty in acquisition of language. This can include deficits. You want to assess both expressive and receptive language. So to what degree do they have impairments in being able to express themselves, and to what degree is this what's going on have to do with what they're able to understand. So this kids have a delay in typically in developing language, and again, not just speech, so sign language, other any kind of formalized system of communicating with symbols. That's what language is, right? So they don't acquire it, meeting developmental milestones. There's some sort of significant delay, difficulty, despite, okay, well, they had opportunity, they had somebody trying to work with them, doing the typical things you would do, but for some reason, this kid's not able to get language. So that can be identified as a disorder, which again will help sometimes get resources to address that. Speech sound disorder. So this is difficulty with speech production, where kids are kind of unintelligible. So they may understand what you're saying, and they may even think you understand what they're saying, but people can't typically understand them. And when I've seen this, often there's a primary caregiver or a brother or sister that is their interpreter, right? That has been around them enough and has kind of figured out what they mean when they say things based on context. And probably some nonverbals, and that's part of what likely allows us to continue to develop, is when you have this kind of interpreter. So it takes some of the pressure off of really needing to learn to be more intelligible. But it can happen for a variety of reasons. Obviously, intervention would be involving a speech-language therapist, a speech-language pathologist. Childhood onset fluency disorder, stuttering. We have a disturbance in the normal fluency and time patterning of speech. Social or pragmatic communication disorder. this is kind of a different one. We have persistent difficulties in social use of verbal and nonverbal communication. So a kiddo that can talk, when they want to about things, and they can understand language, but they have a hard time using language in social interactions. So, somebody says hello, knowing that the proper response is hello, how are you? I'm fine. Kind of those interchanges. Like they know the words and can say the words, but they don't use words to regulate social interaction, right? Which, as we'll see, there's some overlap here with autism spectrum disorder, and kids might be diagnosed with this first, and then figure, oh no, yeah, it was autism spectrum disorder. But sometimes kids have this, but they don't have all the other stuff you see with the autism spectrum disorder in terms of restricted patterns of interest and behavior, stereotype behavior. If they don't have all that, well, it's not autism, but they still have the social deficits. Okay, then here's kind of a label that can be applied to them to help get them intervention services they may need. So, autism spectrum disorder. DSM-5 combined autism disorder and Asperger's disorder, with some controversy around that. The idea being, well, it's really all Asperger's is definitely, part of this spectrum. They share these core symptoms. It just seems to be individuals with Asperger's have less impaired functioning than individuals that were previously diagnosed with autistic disorder. So let's make it all one thing. But some of the folks in the Asperger's community not too happy about that. To be now in this larger community, they like their community and see themselves as being qualitatively different than people who are at a different area of the spectrum. And they probably have a point to that. So, autism spectrum disorder in terms of DSM criteria, persistent deficits in social communication and interaction across multiple contexts. So this is seen in terms of deficits in social emotional reciprocity, right? And that's the give and take of social interaction. One of the big ones that we look for is being able to appropriately use eye contact. And somebody says something to you and you say something back to them, there's this give and take. Non-verbal communication used for social interaction, which again, eye contact, turning towards someone when they're talking to you, reaching out to shake a hand, those types of things. And also development and maintenance of relationships. So tend to seem like they're not that interested in people. There's, especially now that autism spectrum disorder is one big umbrella for everybody on the spectrum, there is significant heterogeneity, variability in individuals that fall in this category. I think one misunderstanding of individuals on the spectrum is that they just don't care about people at all. They don't want to be around people. They don't form attachments. They do. They form incredibly strong attachments. Keep an autistic child with autism from seeing their mom for a week and see what happens. Okay? And again, it's not just something. Oh well, no. It's just like an object. They have a fixed pattern of interest, and the parent is an object. I know kids with autism. No, that's not it. They do attach people. Relationships are important to them, but they don't interact relationally the same way. And some of it seems to be associated with some. There's anxiety related to the way we interact. All right, if you try to make someone with autism spectrum disorder have kind of sustained eye contact, it can be anxiety producing. Right? Uncomfortable with this way of processing the world, doesn't feel good, not going to do it. Right? So I want you to be here, want you to be part of my life, but I just can't interact with you the way that maybe you're expecting. So again, this is across multiple contexts, not just at home with the parents, not just with some friends or school. It's with everybody. They have these deficits. And then the other kind of cluster of symptoms is the restricted repetitive patterns of behaviors, interests, or activities. And this can include things like stereotyped or repetitive motor movements, so hand flapping, spinning, So just doing something over and over again, almost like it seems like almost like sometimes they're well, this is an interesting feeling, huh? That's weird. I'm thinking I'm gonna do it again, and I'll do it again, and I'll do it again, and they'll just keep on doing it like this. They're getting some enjoyment, satisfaction, gratification from that motor movements, providing some sort of stimulation that is rewarding. So it's done over and over again. Inflexible adherence to routines or sameness, right? So wearing the same thing every day, or needing, the sandwich to have the crust cut off the same way every meal. This is my cup. I only drink out of this cup. I'm going to drink out of any other cup. At 9:30 we go here. If we don't go here at 9:30, something's really going to be wrong. I'm going to be very upset. And again, that upset looks a lot like panic and anxiety. It doesn't seem to be, people often interpret as, oh, they're getting angry. But if you really are around individuals that on the spectrum that get pushed out of the routine, before the anger, you see some anxiety, right? Highly restricted interests that are abnormal in intensity or focus, right? So one of my nephews interest in bugs, and can, at 5 years old, can tell you about like any bug you see. What bug is that? And he's like, oh, that's the North American brown da da da. Okay, his favorite food is da da da, and just knows all the details about all these things. Which, at this age and this context, why do you know that much about this? Well, because there's this focus interest. Once they find the thing that they're interested in, they focus on it, right? A lot, and will read and learn everything about it. So you have that, and then also just with younger kids, you'll see this restricted interest in terms of when they're playing with a toy. Like, so you give a kid on the spectrum a car. Most kids will take the car and they'll look at the whole car, and then they'll probably roll it and they'll smash it into the wall, or themselves or somebody else, and they'll roll it away from them and they'll crawl after it. A kid on the spectrum is more likely to look at the car and then find some piece of it that's interesting. Maybe it's a wheel, and they'll look at that wheel and they'll spin the wheel, and they'll spin the wheel, and that's all they'll do. And they won't play with the rest of the car. They're focusing on one part of the object. And if you do kind of eye tracking studies with these kids, you see where their gaze doesn't go around the whole thing of whatever they're looking at. It typically focuses on one piece, which there's some theories about. Well, that's because there's maybe some difficulty integrating multiple sensory inputs, and so you can't, because typically when you're taking in the world, you're looking at way more than you even think about, and you're putting it all together into one picture in your mind. And there's maybe some difficulty with sensory integration with these individuals, so they can't look at, hear, feel everything. They've got to restrict what they're taking in, otherwise it becomes overwhelming. And then you have hyper or hyporeactivity to sensory input. Again, with that focus, sometimes the hyperreactivity, or really some sort of textures that will just drive them nuts, not feel good, can't stand it. I can't wear this shirt. It's killing. Stop. Take it off. Right? And they end up finding one texture of shirt or pants or clothing that they can wear. Can't wear anything else because it just literally rubs them the wrong way. Walking on certain surfaces, like walking on sand or grass, might be unpleasant for them, but also might be the opposite. It might be, they're walking barefoot sidewalk, and they go on the grass, and all of a sudden they stop and and then they just walk in the grass, and they just hyper focus on that sensation, right? Or they find something textured that they're interested in, and they will continue exploring those tactile sensations over and over again. So again, some sort of sensory input thing going on, either wanting more or less of different sensory inputs, which probably functionally the biggest difficulty there is related to food. It can restrict the types of foods that people on the spectrum, or kids, that's what I've worked with, are willing and able to eat, right? Because if you have these texture issues, and they can only eat things that are crunchy or only eat things that are soft, it really limits you in terms of providing nutrition and especially going out to eat, can be a challenge. Okay, so the autism spectrum, more commonly diagnosed in males to females, like a 4-to-1 ratio. I'm not sure why. One thing to think about is whether there's, as I said, significant variability in impairment, right? So the functional impairment, depending on where somebody's at on the spectrum. Again, some people highly functioning, typically in STEM fields, engineers, people that work well with objects and patterns on the higher end side. But people, sometimes you get this idea that, oh yeah, everybody's kind of either they're like that, or they're savants like they show in Rain Man. They have some special ability. That happens with some people, but you also have people on the more severe end that never develop language and are going to need high levels of intervention assistance for the rest of their lives because of their deficits in functioning. To keep them safe and well. And what seems to be able to predict level of need is IQ. So intelligence, the higher the intelligence, the better the prognosis. In terms of causes, well, it's not bad parenting, right, as it was once thought, and it's not vaccines. I'm not even going to talk about why. It's just read the research. It's not vaccines. The Earth's not flat. It's not vaccines. Genetics certainly seem to play a role, and you see, and again, not for just the disorder, but for something that's related to the disorder. So you'll see people with you see deficits in kind of social interaction run in families. With some people meeting criteria for autism spectrum disorder, some people not. One thing that's happening, again, not to say, oh, this causes it, but something that seems to be involved in the manifestation of the disorder, kind of what's going on is, it seems there's an impaired theory of mind, impaired development in the theory of mind, possibly for individuals on the spectrum. And theory of mind being your ability to kind of engage in this type of abstract thinking where you can take the perspective of others and think about how they would think about you, right? And there's some fairly creative research paradigms where you look at this, where you show kids a picture of this other kid who goes and hides a teddy bear in a box on the left, right? Kid A, and then kid B comes in, finds teddy bear and moves it to a box on the right. And then kid A comes back in, who, put it on the left, doesn't know it was moved. And you say, okay, where will this kid look for the bear? And they'll say, oh, they'll look for it on the right, where it is, and not where that kid thinks it is or should think it is, right? Because the idea being that they have difficulty taking the perspective of this other person, and that this person has a mind and can think of things for themselves. And that's something that neurotypical kids can't do for a couple of years, and then around 4 or 5, they're able to do that task. They're able to solve that problem. Oh yeah, they would look here. But kids on the spectrum eventually can do it, but there's a delay. It takes them longer. So that may be part of what's going on, is this ability to take the perspective of others. I think your book also talked about, related to that, this idea that their concept of self may be impaired. Again, why is it impaired? We don't know, but that maybe these are kind of some of the psychological functions involved in the ideology. Again, right now, just very theoretical. In terms of interventions, and again, not treatment, because we're not looking to fix people, but how can we help people be the most successful? Be very aware of cures. Oh yeah, just this diet is what you do. You need to be no more gluten, or only eat purple foods. No, there's no empirical evidence of those things working, right? You have these anecdotes where, oh yeah, my kid, they had autism, and then we did this, and now they don't. Okay, maybe, maybe. And I've seen kids that were meeting criteria, and then something happened, and they no longer met criteria. Now, the question is, were they cured or were they misdiagnosed? And in my experience, the ones I've seen, typically they were probably misdiagnosed. There was something else going on. Often, because one of the big things we look for autism in kids is a language delay. And you get a kid that's, 2 or 3 and not speaking much, not even using one-word sentences. Oh, this kid, I think they're autistic. And then something happens and they can hear again. And you find out, oh, they had chronic ear infections where, they were hearing like Charlie Brown's teacher going, wah, 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 and those cleared up, those resolved. And then all of a sudden, hey, now I can speak and use language. And once I can use language, that changes how I interact socially, and all these other things change. So again, not to discount that maybe some people do have miraculous cures, but be skeptical. The science hasn't documented these things as effective as of yet. So there aren't cures, but there are lots of interventions where you can teach social skills, and you can help families learn how to modify their environment to help kids be the most successful. One of the things is this need for sameness, right? So taking trips can be really hard. So instead of just trying to get the kid to go, okay, just get over it, deal with it, well, let's adapt the environment to help the kid be most successful. So if you're going to take a trip, then a couple weeks before you take the trip, you take a day trip just to the airport. And before you take the trip to the airport, you show them pictures of the airport. And it may be like kind of the comic book type thing where here's going to be us getting in the car. We're going to get in the car. Then we're going to go down this road. And we're going to turn here. And then we're going to see the airport. We're going to walk in. We're going to sit on this couch. And then we'll come home and we'll do what is something that you like to do, read about dinosaurs or whatever, right? And you're gradually moving up to this big shift in schedule, but doing lots of preparation, using, kind of pictures, kind of comic book thing to prepare over and over again. This is what's going to happen, and that can help. So again, not just saying, let's help them stop feeling the anxiety. Well, let's do things to make them less anxious about changes. There's also for especially more severe folks on the spectrum, ABA, Applied Behavioral Analysis, developed by Lovas. This is where you're training kids to do things, skills, using micro steps, right? So this is a kid that you're trying to teach them to use a spoon, right? And they're 5 years old, and you're going to spend a month working on put your hand on the spoon, put the spoon in the bowl, get the spoon to your mouth, right? There may be another month involved with pulling the food off of the spoon and swallowing it, right? Where you're doing, shaping, rewarding of successive approximations, where there's this whole complex behavior, right? You may not think of eating with a spoon as a complex behavior, but it is, where first you're rewarding reaching for the spoon. And that may take a while. Successfully, each time they reach for the spoon, reward, reward, reward. And then once they do that, you stop rewarding that, and you don't reward until they grab the spoon, right? And then they do that successfully. Okay, now you don't reward until they bring the spoon toward their mouth. See where I'm going? Where it's a slow-going, focused training with rewarding behaviors, one step at a time, building to teach a complex set of behaviors. Again, with the hope being that if you can teach enough behaviors, that then you'll start seeing some generalization. Okay, we trained you to use this spoon, and now that will generalize to where you can use a fork, maybe, or we do this. We worked only on cereal. Maybe you can do it with yogurt as well. So again, not training everything, hoping for some generalization, but a lot of micro training. Okay, ADHD. A persistent pattern of inattention and or hyperactivity impulsivity that interferes with functioning or development. Right? So you can have just the inattention symptoms, you can have just the hyperactive impulsive symptoms, or you can have both. Right? So if you have inattentive symptoms, you need to have at least 6 symptoms of inattention. It won't list all of them, there's just several. Largely different ways of saying having a hard time paying attention or focusing, but also things related to having a hard time paying attention and focusing. Difficulty organizing tasks, don't like doing things that require sustained attention, being forgetful. And again, it's not this, the idea being the forgetfulness isn't a memory impairment, as though you forgot to do the thing I told you to do because you weren't paying attention when I told you to do it. So 6 more symptoms of that, and or 6 or more symptoms of hyperactivity, impulsivity. So fidgeting, talking excessively, interrupting, blurting out, those types of things. And several symptoms of inattention or hyperactivity must be present prior to age 12 and occur in more than one setting. So does that mean if you're 15 and you think, oh, I think I have ADHD, you can't meet criteria? No, you just need to retrospectively, based on the child's report, the parent's report, even as an adult, thinking back, okay, yeah, when I was a kid, before I was 12, was this stuff going on? Oh yeah, I used to always forget stuff, and I never could stay in my seat. Okay, well then maybe you meet criteria. And then the other important part here is occurs in more than one setting, right? So if they're only showing this hyperactivity whenever they're in a setting where they're expected to sit at a desk and not get up for 4 hours at a time, but at home, yeah, they're working on homework, sitting at their kitchen table. Yeah, a good 30 minutes, hour, they can sit there and do the homework. That's weird. Well, it's not ADHD. It's something about the environment is making them fidgety, causing inattention. Either sensory overload, sensory underload, understimulation. So it has to occur in more than one setting. Excuse me. But it's also important to remember that, because sometimes people say, oh, well, these kids, they say they have ADHD, but man, that's not even a thing, because why? They can sit and play video games. Well, yeah, because video games have lots of moving, flashing lights and things moving and sounds that's a high demand for your attention. Right? So people with ADHD, it's not that they can't pay attention, right? They don't have an intellectual disability where they can't focus at all. It's they have difficulty sustaining their attention when there's some sort of something boring's happening, basically. Like when you need to focus, okay, I gotta stay on this. You can bring to bear this cognitive function of attention for people kind of neurotypicals. But with ADHD, when you need to, it's more difficult. And watching video games, you don't need to. You don't need to focus because your focus is being pulled from you. There's a high demand. Same thing with really entertaining movies. Right? It's easy to focus. You don't have to focus. You're just sitting there passively taking in the information. So again, it's not that they can't pay attention. It's just they have a harder time focusing attention whenever something isn't particularly interesting to them, which we all do to some degree, but there seems to be a matter of degree here where they have more of a difficulty to the point that it's causing impairment. So there's gender differences in ADHD, more often diagnosed in boys. And probably some social cultural reasons for this in terms of gender roles. When it is diagnosed in girls, you see more often the inattentive symptoms being seen there, and in boys more than girls seeing the hyperactive symptoms, and that probably has to do with the socialization of boys and girls, where it's okay for kind of normal, typical boys to be a little hyperactive, a little rowdy, and that's often discouraged in young girls. And so they may be pushed in different directions in terms of how the thing is going to manifest. In terms of the course, across the lifespan, how the attentional deficits, the hyperactivity manifests tends to change, right? You don't have the same symptom necessarily across time. But for a lot of people, the deficits, the impairments continue in some form throughout the lifespan. So a kid that's ADHD as an adult is still going to have some difficulties with attention. Maybe not the same ones. They've learned some skills and learned to cope, but they're still struggling to some degree. But one thing we typically see is a decline across age with hyperactivity, which again, that's also somewhat normative. For kids that don't have ADHD, you see a decline in hyperactivity as you have an increased societal demand to settle down. In terms of causes, like most things, it's probably a combination. Largely, there's certainly a genetic influence, but the heritability rates aren't anywhere close to schizophrenia or bipolar disorder. But there's some genetic component to inattention, impulsivity. Certainly, there seems to be this a neurologically influenced phenomenon where there maybe the brain is functioning differently, maybe some structural differences. And again, when we look at these structural differences in the brain in these studies and say, okay, well, these individuals with this disorder, they have a smaller this or bigger that. Whenever you read those studies, it's never all the people that have it, and it's also never all the people that don't have it that have this consistent pattern. But there's some people enough to see that it's a pattern, but it's not everybody. So maybe that's because it's multiply determined, or maybe it's coincidence. We don't know. But certainly there's something going on in the frontal cortex, right? That's where you have your inhibition centers. Whenever you need to block out stimuli and focus, when you need to I'm hungry, but I can't eat right now because I got to focus on this. And if your brain needs to send signals to, hey, other part of the brain, shut up, I got to do this. That's the frontal cortex that's sending those messages out, which suggests that individuals with ADHD probably have some sort of deficit or difference in that area of the brain. And also, it seems that the medications that work target that area of the brain. But there's probably also, as always, some role of environmental feedback. Right? So maybe there's some sort of biological predisposition, and again, depending on how the environment reacts to that kid, that will make them more or less likely to develop more symptoms of inattention. Right? Which one thing being, if you put kids in a cultural setting where you expect them, at age 6 to sit in a classroom for 8 hours a day, okay. Are they going to then develop a pattern of inattention hyperactivity more likely than a kid that at age 6 is running out in the fields playing or working, whatever? Yeah, probably. If you have different demands on attention at an early age and across the developmental lifespan, that's probably going to affect the degree to which you struggle with attention and how you begin to think about yourself and your ability to pay attention. In terms of treatments and interventions, medication being one of the most widespread interventions. Psychostimulants like Ritalin. You think, well, that's weird. Why stimulants to calm you down? Well, I think it's stimulants to activate the part of the brain that inhibits, right? So you're turning up the thing that turns down. And if you see, well, that doesn't make any sense. Well, if you ever need to focus and you drink some coffee, well, it should make sense. Coffee is a stimulant, right? Helps you focus. Same thing is going on with these psychostimulants. Other meds that are used, just anything in the cabinet, it seems sometimes, in terms of blood pressure medicines, anti-seizure meds, I don't know, probably hair loss meds, who knows. There's a wide variety of things that have been tried with kids with ADHD. Most of them, though, seem to be things that generally, if it's not a psychostimulant, they go the other way and look for something that's going to reduce neural activity, to calm kids down, sedate kids, basically. Works for some people. Behavioral interventions, also important in terms of teaching people coping skills, how to structure their environment to increase the likelihood that they can be on task and concentrate and deal with the demands, the attentional demands placed on them. One important thing to note is whenever medications work for kids with ADHD, where, okay, when they're on the meds, yeah, now they can focus. Now they're not hyperactive. Great, it's working. When it works, the success stories, those kids don't typically, on average, show improvements in academic and social functioning unless you add behavioral intervention, right? So they're no longer hyperactive, they're able to focus, their grades don't get better. They don't stop getting in trouble. Well, what the hell? What's going on? If we fix the kind of the brain thing that's going on, why are they still having the functional impairment? One hypothesis is that that functional impairment, the getting in trouble, the having difficulty in school, is something that develops over time, right? And there's patterns that develop around that of interaction expectations. So once your kid has these patterns, expectations around them, once you change what's going on with them, well, they're still in a system that will be resistant to change, right? So this kid who's been a troublemaker for the past 3 years in school and has a reputation of being a troublemaker, but now they're able to sit still, and they're calm, but they're sitting there and they have a question. They raise their hand, and he goes, Johnny, quit fidgeting. I was just raising my hand, because there's this expectation that, oh, they see this kid this way. Same thing for other kids. Oh, this is the kid that if we tell them to do something, they're crazy. They'll do it because they're impulsive. They'll do whatever. And so the kids who are going to influence you to do bad things are still going to glom to those kids and push them into antisocial behavior sometimes. So it takes more than changing how the brain's working to change what's going on in these kids' lives. It takes behavioral interventions in terms of impacting the system around them to really see any kind of changes in functioning. Specific learning disorder. This is one where the DSM's taken several different learning disorders, dyscalculia, dysgraphia, and put them all under just one label. So difficulty learning and using academic skills for 6 months at least that persists after intervention. So you can't read, can't spell. We tried to help you, still having problems. So it could be inaccurate or slow and effortful reading, so some decoding problems. Or another reading related thing, difficulty with reading comprehension, so they can read out loud, but then you ask them, what happened in the story? And no idea. Within these reading deficits, one time referred to as reading disorder, now specific learning disorder, sometimes referred to as dyslexia. Dyslexia, a complicated label that means, difficulty reading and decoding, but often is assumed to mean, oh, you see words and letters backwards. Some people do, but not always. There's lots of different reasons why people might have difficulty reading that can go under the label of dyslexia that doesn't necessarily involve transposition of letters. Difficulties spelling, difficulties writing, written expression, difficulties with math in terms of basic number sense, number facts, calculations, adding, subtracting, or the more abstract mathematical reasoning. Right? So in some area of academics functioning skills, kids just not getting it. And where they don't seem to have intellectual disability that's involved here, you're not going to tack on specific learning disorder on top of that. This is kids that typically are neurotypically functioning, but then one area, something's going on. So it's not in the DSM, but in clinical practice, when you're identifying a specific learning disorder, there's been a shift in how it's done. For a while, they used the discrepancy model, right, where you look for, okay, you need IQ to be here, up at 115 or something, and then achievement to be lower than that. Typically one standard deviation below that. So you're at one standard deviation above the mean on your IQ, but your achievement in reading or math is at 100, so it's lower than it should be. The idea being your achievement and your IQ should be the same. If you're doing great on this IQ test, you should do great in achievement. And if you don't, there's discrepancy, oh, that's a learning disorder. And for a long time, that's how it was conceptualized. More recently, people have realized that's not a great idea for a variety of reasons. One, if you have a learning disorder, you have a hard time decoding words, that's going to influence your performance on this IQ test, right? Because IQ tests, for a lot of people, think, oh, they're pure measures of intelligence, but they're not. They're definitely influenced by education and academic skills. So if you have a hard time reading, you're not going to do as well on that test, and so you're going to have crap achievement, but you may also have low scores on the IQ test, and you don't end up getting that discrepancy. So now what you look for is a deficit in achievement. Okay, a kid is not achieving what they should. They're below average, and 1.5 more often, 1.5 stimulations below the mean. Okay, most kids are reading at this level. They're this far down in terms of their reading skills or number recognition, whatever it is. And then you look for a deficit in cognitive ability that helps explain that or matches that, right? Because the whole thing with IQ testing now is nobody really cares that much about the big number, the IQ number. I mean, people online love that number. But in terms of assessment, there's lots of little numbers, right? There's subcomponents of intelligence in terms of processing speed, memory for words, memory for numbers, ability to identify patterns, to mentally rotate objects, all different kind of sub skills, cognitive skills that you're measuring. And so you're looking for a general pattern where, okay, generally their intellectual functioning is up here, but there's this one part of intellectual functioning, of cognitive functioning, that they struggle with. Okay, so they're down here on this. Oh, and that makes sense that they would have a hard time in math class because they can't, when they look at numbers, it doesn't make sense to them. Or whatever it is. So instead of looking for discrepancy, you're looking for a sameness, where, okay, you have low achievement in an area and then also a deficit in some sub area of cognitive functioning. Okay, the motor disorders, developmental coordination disorder, again, kind of a delay in motor development. So acquisition and execution of coordinated motor skills are below expectations for age and opportunity and ability. So the kid, should be walking now, but they're not, or they're just particularly clumsy. So there's something going on where they're not able to coordinate their motor movements. Stereotypic movement disorder. So repetitive, seemingly driven, and apparently purposeless motor behavior, which again, you see that sometimes in the context of autism spectrum disorders, sometimes in the context of intellectual disability. You don't typically add it to an autism diagnosis, because that's really part of the core feature. But you might add it to intellectual disability if it's something that needs clinical attention, especially if it's self-injurious behavior, like head banging, where they're repeatedly over and over banging their head against the wall or hitting themselves in the head with their hand. You would add this label to help kind of direct clinical attention and focus to deal with that. The tic disorders, so Tourette's, where you have both motor and vocal tics, right, where this irresistible urge to do something, and you just do it. You can't stop. And often it's subtle. A little twitch of the neck or the hand. The vocal tics, most often kind of grunts, vocalizations. Sometimes you have the the words. Sometimes curse words. That's what the media loves to show. Sometimes, not always. More often it's grunts and non-word articulations. And then if you just have a vocal tic or just a motor tic, then it's persistent motor tic disorder or persistent vocal tic disorder. Again, if you have motor and vocal, then it's Tourette's. One interesting thing to note is there's this interesting pattern of comorbidity, especially familial comorbidity, where if somebody in the family has this, somebody else's family might also have this, related to Tourette's, ADHD, and OCD for some reason. So maybe there's some sort of genetic vulnerability, shared genetic vulnerability to those disorders. Maybe. Okay, moving on to the neurocognitive disorders. So these involve impairments in cognitive functioning, and they're typically have an identifiable underlying syndrome, right? Where for most other things, the DSM like, well, yeah, depressed, and could be a variety of reasons. For these, oh no, yeah, you have this neurocognitive disorder, and it's because of Alzheimer's, it's because of HIV. So there's often some sort of disease process or substance physiological process that, yep, this is what happened, and this is why you have this having these symptoms. It's a little different. DSM-5 moving away from the term dementia, particularly for younger patients. I don't really know why. And the onset is typically in older adulthood for neurocognitive disorders. Not always, but that's kind of the the norm, where those neurodevelopmental ones, we typically see onset early, and now we're looking kind of on the other end of the age, the lifespan, in older adulthood, where we see more commonly the onset of neurocognitive disorders. Okay, delirium, a disturbance in attention and awareness that develops over a short period of time and represents a change from baseline, right? So if somebody, you say, oh, they're delirious, they're out of it. Yeah, they it's not like they can't pay attention, like, yeah, I just can't focus today. It's that they aren't focusing on anything. They aren't aware of sometimes who they are or where they are, and it comes on pretty rapidly. So in addition to this disturbance of attention and awareness, not able to focus, not sure where they are, there's some other disturbance in cognition too. So possibly a memory deficit, some amnesia. I don't know who you are. Disorientation, again, not sure where they are. Perceptual disturbances. So you could have hallucinations with delirium, right? Where it can look like a psychotic episode for some individuals. Now, typically, when we have a DSM diagnosis, we always have this criteria. So, oh, it's not due to another medical condition or better explained by another disorder. Delirium, it's the opposite. Well, to meet criteria, yeah, it has to be due to some other medical condition, a general medical condition, GMC, substance intoxication or withdrawal, or toxin exposure, or some sort of physiological reaction. There's a reason this is happening. If there's not, okay, then it's probably a psychotic episode, right? And that's kind of the difference between delirium and psychosis is, so the psychotic episode is part of, schizophrenia, schizoaffective disorder, mood disorder, psychotic features, where that's going on. Delirium is more of this psychological manifestation of something that's happening physiologically. The treatment obviously depends on the cause, right? If it's for substance intoxication, well, there's certain medications we can give you that will counteract the effects of the drug you took. Same thing for withdrawal. We can give you, some agonists that will mimic that drug enough to stop it. So it just depends on what's going on. But generally what you want to do is provide reassurance for the person, right? And it helps if someone they know is there and can kind of help keep them calm, because it is something that it'll pass, right? And delirium kind of waxes and wanes. It shows this episodic pattern. So if they can kind of keep them calm, keep them safe, so until medical personnel can intervene with whatever they need to do, they'll be okay. Okay, the major and mild neurocognitive disorders used to be called dementia. So this is where you have cognitive decline from a previous level in one or more cognitive domains based on, so how do you know there's cognitive decline? Either the person tells you, yeah, I can't remember things anymore, I can't find words, or a knowledgeable informant, so this is typically, partner or spouse or child of the person saying, oh yeah, they're different than they used to be. Or the clinician, their doctor says, yep, this is a decline. This isn't just normal aging, right? Because physically, we all peak in terms of potential at about 25, right? You may not physically peak at 25 because if you didn't get to your potential yet, you still have room to go. But if you're at your full potential 25, well, it's downhill from there. And we see declines in speed of processing neurologically as part of typical aging. It begins to speed up around 65, but not to a degree that's all that noticeable, right? It may take you a little longer to process information, but often that's offset with the increase in wisdom and experience. So objectively, you don't really see that much change in typical aging. In a neurocognitive disorder, which is not typical aging, there is a observable decline. People can see, oh yeah, you're having a harder time than you did before. So people are seeing it, and there's a substantial impairment in cognitive performance that's documented via testing or other assessment. So IQ tests, or more often neuropsych tests. We get a full neuropsych battery to rule out other kind of organic or identify organic brain disorders, strokes, tumors, that type of thing. So to be major or mild neurocognitive disorder, it doesn't occur only in the course of delirium. So it's not something that kind of comes and goes, waxes and wanes. This is more of a chronic. Things have gotten worse, and now the decline has been steeper than it was. We've got a steeper drop off, and it doesn't come back up. Like with delirium, you come out of the delirium, and you now I can remember. Now I know who you are. With a neurocognitive disorder, the deficits don't get better. And again, to make criteria, not better explained by another disorder, right? Because you may have some cognitive decline associated with schizophrenia, but that's just part of a thought disorder. The onset depends on the cause. I won't list all of them, but in terms of some differences for Alzheimer's related neurocognitive disorder, it's a gradual onset, right? So it's kind of they often use the word insidious, right? It sneaks up on you, where just a little more and more each day. Whereas vascular disease, so somebody has a stroke, tends to be abrupt, which makes sense because that Alzheimer's disease is this disease process that's slowly causing this brain damage, plaques and tangles in the brain. Whereas a vascular disease, a stroke, you're having some sort of event where oxygen to the brain is being cut off in some area, causing cell death. Some of the course and pattern of deficits depends on etiology, with vascular disease being kind of this patchy pattern of, okay, some deficit here, but this is fine, but this isn't fine. And again, it depends on, well, where did you have the brain damage from the stroke? With, again, different diseases having different parts of the brain they affect, and that will dictate the symptom pattern. But the course is, it's not going to get better. And you can slow the decline with some medication, some interventions, and you might even be able to get people to kind of flatline plateau in terms of their loss a bit, but rarely do you see recovery of cognitive function to kind of a pre-morbid level so far. But there are some really intriguing possibilities out there with stem cell research that maybe in the future this will be reversible. Right now it's not. Often, again, depending on etiology, these neurocognitive disorders may be associated with changes in personality, right? So if the part of the brain being affected includes that frontal lobe, which is the seat of personality to some degree, you may see some changes in personality, more impulsive, more aggressive. Well, what's going on with grandpa or grandma? They're acting weird. Well, it may be this neurocognitive disorder. If you got a fairly high rate of comorbid depression, about 25%, not surprising, right? Because you're aware that you can't remember things as well, and that's depressing. If you feel things slipping away, and often there's an associated loss of independence. People say, oh, well, now you can't drive anymore. Now you've got to be taken care of. That's a real threat to identity, and is not surprisingly associated with depression. Related to that to some degree, there's also something that's referred to in clinical lore, not in the DSM, as pseudo-dementia, where people can look like they have dementia, what we formerly call dementia. They can look like they have a mild neurocognitive disorder, but really it's depression, right? And this is, okay, wrapping up, take home. The neurodevelopmental disorders, early identification, intervention, super important, make a huge difference, right? Regardless of what we're talking about in terms of autism spectrum, ADHD, intellectual disability, the earlier we can identify that, okay, this kid, we're talking about early intervention, may have some difficulty. If we can provide appropriate intervention, we can change their developmental trajectory to where make them more likely to be successful living independently and more likely to realize their potential, and also in several instances more likely to not meet criteria for a disorder later in life. Looking at the neurocognitive disorders, take care of yourselves, stay healthy. Physical health is strong predictor of neurocognitive health in old adulthood, right? Because again, one of the things that can cause a neurocognitive disorder is vascular disease, right? If you're having a stroke, so watch your cholesterol, don't eat lots of fatty foods, exercise, stay active. Believe me, you'll be grateful you did if you're an older adult and you're able to be more cognitively healthy. It matters. Related to that, stay cognitively engaged and socially engaged. That matters too. We see greater impairment in older adults as they become isolated, and if they kind of just stop doing things. Yeah, I'm just going to sit home and watch TV. Oh God, you're in trouble now, right? They've got to keep reading, doing puzzles, talking to people, interacting for psychological, physical, and cognitive health. Last bit, dementia is not normal aging, right? So it's not, oh yeah, when people get old, they just can't remember anything. No, there are some declines in processing speed and impairments in memory associated with age, but not to the level of dementia and neurocognitive disorders. That's usually something happens, some sort of disease process, which again, taking care of yourself, you can reduce the likelihood of experiencing disease process. You maybe can't have a 100% chance of preventing it. Some things are beyond your control, but do what you can. That's all for now. Take care.